going to start first with at today's SIG session. I'm going to talk about a brief overview of CNO and our work group's progress thus far. But first, I want to introduce the group today to what our key discussion questions will be later on, so that you can think about this as I go through the presentation and when we discuss later how we will answer these. And so the first question will be, do we need a core domain set? And I will explain that later on for chronic non-bacterial osteomyelitis, or CNO, I'll say that a lot, and synovitis, acne, pustulosis, hyperostosis, and osteitis, or SAPHO. And then the second question, which will kind of probably, I guess, be a bulk of the discussion, it'll, how are we going to develop this core domain set for CNO and SAPHO, and should we be considering one all-inclusive or separate domains, and think about how we're going to incorporate pediatric and adult and the two different, maybe different disease entities. So first I'll start off, like I said, with a background. Most of us know these diseases, but for those of us who don't, so what is chronic non-bacterial osteomyelitis? Many of you might know it by the other name, chronic recurrent multifocal osteomyelitis. However, it doesn't need to be recurrent nor multifocal, so the nomenclature is trying to push it towards chronic non-bacterial osteomyelitis, but chromo is the name that's probably still mostly published in the literature today. Typically, patients will present with bone pain. They can have normal or maybe mildly inflammatory markers and X-ray findings of either lytic lesions, or on MRI you might see hyperintense signals. It's an auto-inflammatory bone disease. We don't know the underlying cause at the time, but over the photo that I'm showing is just some of the more commonly affected bones in CNO. So I mentioned SAPHO. So what is SAPHO? Again, it's synovitis, acne, pustulosis, hyperostosis, and osteitis. And calling it at the moment a related condition, but some of the discussion later on I'll show you may not necessarily be a separate disease, could be a spectrum of the disease. Typically, patients will present with, as the name entails, bone, joint, and skin symptoms. And within the bone, the most probably common area, or something that's very distinct with it, is that costosternoclavicular region is commonly affected. So how common are these diseases? Not very common, but there may be a thought that it could be underreported. But what's been reported out there is that the annual incidence of CNO is estimated to be about 0.45 per 100,000. It's predominantly in children, but it can extend into adulthood. SAPHO, the prevalence is estimated to be about 40 per 100,000, and with SAPHO, that also can be found in children and young adults, even though it's sometimes thought to be more an adult disease. So what kind of are we dealing with SAPHO and CNO? And are we dealing with the same disorder that presents as different age groups? Or are we dealing with distinct disorders that are just on some spectrum of the disease of different phenotypes? Patients with CNO or chromo, they can have some of these other features that are similar in SAPHO, so skin involvement with acne and palmoplantar pustulosis. They can have arthritis as well too, and some overlap with the spondyloarthropathy spectrum as well. So briefly, the pathogenesis, it's thought to be an autoinflammatory disorder. There is impairment in innate immune responses and an imbalance in cytokine expression with, there is a lack of autoantibodies as well too. There may or may not be an infectious trigger. So cultures from the bones of patients with CNO from bone biopsies are generally thought to be sterile. However, in a recent review, they had found that about 50% of bone biopsies had Cutibacterium, or previously known as Propionibacterium acnes. However, a lot of those that had been reported to have that were also patients who had a predominance with skin findings as well. But the thought maybe could be that maybe it's actually a trigger and not so much a contaminant. And then I'll just briefly mention that there are monogenic autoinflammatory bone diseases that have similar features to CNO. And that is DIRA, or deficiency in IL-1 receptor antagonist, and MAGED. DIRA has a mutation in the IL-1 RN gene, and then MAGED has a mutation in the lipin-2 gene. For the sake of this group, we have kept these separate from the overall generation of the core domain set. So we're primarily focusing on the CRMO, non-genetic mutation form, and SAPHO. There's no diagnostic test for CNO, so diagnosis is generally still a diagnosis of exclusion. Imaging is important with coming up with a diagnosis. There are some typical findings that you can see on X-ray and MRI, although you can't clearly distinguish between infectious osteomyelitis and non-infectious osteomyelitis on imaging. Bone biopsy is also an important component of making the diagnosis, and that is some of the, that's the pictures off to the side showing at the top, early stage with predominance of neutrophils, and then progressing to a chronic inflammatory phase in the middle with a predominance of lymphocytes, and then at the bottom, chronic fibrosing stage. There are some diagnostic criteria that are out there. There's the King criteria, Janssen and Rotter criteria for CNO, and then for SAPHO, there's the Kahn criteria and Ben Hamu criteria. Many of these still really need to be validated beyond a single center. And one thing that I'll mention that the group is also doing, we are working with ACR and EULAR, and the group on it is developing classification criteria. So general first-line treatment for both is NSAIDs. However, NSAIDs have really only shown partial efficacy in both CNO and SAPHO, and many patients have needed to move on to additional therapies, including disease-modifying anti-rheumatic drugs such as methotrexate, TNF inhibitors, and bisphosphonates. So when evaluating our patients and assessing their response to therapies and improvements, you know, how do we do that? There have been some criteria, some outcome measures or clinical response criteria that have been developed. There's the PED CNOs, and then there is the from the CTP, or Consensus Treatment Plan through CARA, we developed criteria for treatment failure. A lot of these, or both of these, kind of focus on some imaging findings, pain, and inflammatory markers. But there hasn't been a core domain set recommendation for CNO or SAPHO through a standardized OMERACT methodology. So that is how this working group got formed. And so our work group mission and goal is to develop a core domain set through the OMERACT methodology, specifically the 2.1 filter framework, which is what I'm showing in that photo here. And this core domain set is intended to be used for all clinical trials and observational studies. So there are 4 core areas. You can see that at the top of the picture, where it's manifestation, pathophysiology, manifestation abnormalities, life impact, death, and societal resource uses. So through the literature review, which I will talk about, and qualitative research, we will generate a list of candidate domains. And then through our working group meetings and Delphi surveys and voting, we will ultimately come up with our final list. This is an example of that previous OMERACT framework from the psoriatic arthritis work group that Dr. Mees has lent me very graciously to just kind of show and get a general sense of what it will look like once we start to go through the candidate domains and start to narrow them down. And you can see that for the life impact and pathophysiological manifestations is where we find a lot of the domains, candidate domains are being reported out in the literature. So this is just an example of what we are aiming to go towards. So where are we right now?
Melissa,
Yeah.
do you mind going back one slide?
Sure.
So this may be a moment or a segue to sort of make a comment about, so the history of OMERACT goes back quite a long time. I've been with OMERACT for about almost 2 decades, and of course Peter Tugwell, who's on with this, is the originator of OMERACT. And part of the point of OMERACT is obviously to try to bring order to what might otherwise be quite a disparate set of either what do people consider to be the core set that constitutes a disease. So if you think about a circle and then think about all the things that constitute a disease within that circle, ranging from pain to pathophysiology to impact on physical function to quality of life, et cetera, et cetera. And then what are the kind of key elements of that disease? In the case of rheumatoid arthritis, for example, it's going to be synovitis or the arthritis component. There will be some extra-articular features as well. Fatigue, patients have taught us, is an important thing. And then in psoriatic arthritis, as is shown here, we are recommending that every clinical trial that's done do at least this minimum set of evaluations. So evaluating inflammatory musculoskeletal disease, and evaluating psoriasis activity, looking at biomarkers, as well as measuring, especially with patient-reported outcomes, items that impact life, pain, function, et cetera. And what is fascinating, I have found over the years working with different OMERACT groups, be it rheumatoid arthritis or spondyloarthritis or psoriatic arthritis or gout or osteoarthritis, is how similar and overlapping these features are amongst them when you really boil down to it. And so I have a feeling that, as Melissa will show you soon, when you really distill CNO, you're going to come up with some very similar kinds of things. Maybe not, you won't have psoriasis as part of it, but there will be other features that are very common. And so, again, this is for the purpose of bringing order to how a disease is defined and investigated in clinical trials. This is the beginning step. The next step beyond creating a core set is to create a core outcome measure set. So once you've defined what are the key items that constitute a disease, how do we best measure those? And then looking at that in all of the appropriate psychometric ways. Are we measuring what we think that we're measuring? Is this reliable? Is there good inter-rater reliability in doing the measurements? Is it physical exam? Is it patient-reported outcomes? Is it imaging? And so all of those things can then follow this core set of domain development. So I'll stop there and Melissa, take over again.
Great, thank you, Phil. So where's our working group right now? There are generally 3 kind of big phases within OMERACT: generating, agreeing, and voting. we're obviously early and pretty new and young, and so we're in the generating phase, looking through our literature review and working on our qualitative research with focus groups. So this is the OMERACT master checklist. So each working group has a workbook, and we're in the process of finalizing our workbook so that we can submit it to the technical advisory group. However, the one thing I do want to point out is that we have been a little stuck on getting, I think, all of our stakeholders. We're very good with the clinicians and the patient and parent partners, but I think other stakeholders, we still need some industry researchers as well too. So hopefully through the SIG as well, we can identify some more stakeholders, and you'll see my contact information at the end of this presentation. So we are also moving forward, and we're in the generating the candidate domain phase with our literature review and our qualitative research. So I'll go over our literature review, what we've been doing so far. This is our PICO question. And so our population, we had decided to do all patients with CNO and all patients with SAPHO. All subtypes, meaning we had also looked into patients who are presenting with just mandibular CNO, and then also clarifying that we were including the SAPHO patients as well too. And all ages as well, so pediatric and adult. With any intervention, with our control being the standard of care, and the outcome is what we're currently developing. Core domain set is under development at the moment with the plan to utilize this in all trials. So this is our literature review. We're doing a scoping review. We have identified 4,821 articles through an OVID and PubMed search. After duplicates were removed, we had a little over 3,000. And through screening with a wonderful group that I have that we meet twice a month, we have excluded about 2,400 articles and narrowed that further down to 579. And then with those, we screened the full text and excluded things that weren't relevant, wrong article or study type, they weren't English, any more duplicates, and wrong patient population. And we are in the data extraction phase of the 273 articles that we have included in our scoping review. So this is a breakdown of the article types in our scoping review. So there are no RCTs or randomized controlled trials, which we were not surprised. There's a lot of the articles are observational articles, with many of them being retrospective cohort studies. We do have a fair share of case series that we have included, and we really only limited it to case series. We excluded case series if there was less than 3. And the primary reason for doing that early on was because we weren't sure what we were going to get out of our literature review, if we were going to get a lot of articles. And so we do have a big bulk of case series with patients with less than 10 patients in the series. And we are still in the process of doing our scoping review. We have a good number of the primary reviewers completed, and about 121, and completed together with the primary and secondary review, we had about 25. So from those 25 articles, I started to generate our list of domains, and this looks very extensive. And from here, though, the plan is to narrow this down to the 7 to 9 that is including deaf candidate domains. And so you can see we still have a lot of work ahead of us. But a lot of what we've noticed so far is similar, where a lot of the candidate domains, or what's being reported as outcomes in these studies, have fallen underneath life impact and pathophysiological manifestations. And as you can see, if you read through the pathophysiological manifestations, you can definitely narrow this down further and further until we finally get an example of what would potentially be our end result. And again, this is the This is the framework 2.1 for OMERACT, similar to what Dr. Mies had showed with the psoriatic arthritis group. That was a 2.0, so this is 2.1. So our goal would hopefully be to develop something very similar to that, where we have, you know, in our pathophysiology, bone, maybe radiographic, maybe inflammatory markers, and life impacts and pain and function and global assessment scores, with maybe SAPHO just also adding in some skin, skin domain as well too. So our working group's next steps, we're going to continue our literature review, and we will also begin to work on the qualitative research part of the process, and before we can generate our list of candidate domains and then prioritize them. So we have a plan for our qualitative research strategy. We have not implemented it yet, but we would like to work with a qualitative methodological expert and collaborate with them to develop these online discussion boards so that we can reach a bunch of people. We had discussed doing in-person focus groups. It's probably not the best idea to do that nowadays, but with everything that's going on. So the online discussion board is really going to be key. And across 4 continents, we have a plan to do it in the United States, develop one in Europe, Australia, and then in South America, specifically Brazil. And through the online discussion board, we will get our parents and patients and caregivers feedback about what they feel are candidate domains that they would feel are important to be included in all these trials. And then this is the ultimate end result, the OMERACT onion. And so after generating our candidate list and narrowing it down to our final ones, we will then kind of place them in and categorize them into the OMERACT onion in order of importance, with the inner onion or the inner circle being on mandatory domains. So all domains that are we feel are important to be included in all trials. Now, the way that this is set up is that you can allow for some domains that you feel are important, but maybe not mandatory, to also be placed within here, and that could be the optional domains. And then the outer layer is the research domains. So this is our ultimate end goal that we will come up with. So now we will move on to our group discussion and go back to those questions that I introduced in the beginning. So here they are for a refresher. So first is, do we need a core domain set for CNO and SAPHO? In some of the pre-reading material that was on the OMERACT webpage for us, I put up the papers that discuss the PED CNO, and then also the criteria for treatment failure from the Consensus Treatment Plan, or CTP. I do have them here for your refresher as well too, to kind of look at. So the PED CNO includes SED rate, number of radiological lesions, severity of disease estimated by the physician, and then severity of disease estimated by the patient or parent, and a CHAC score, childhood health assessment questionnaire. Through this, the definition of improvement would be, if you can look at it with a PED CNO of 30, 50, or 70, meaning 30%, 50%, or 70%. So at least 30% improvement in at least 3 out of the 5 core set variables, with no more than 1 remaining variable deteriorating by more than 30% would be the definition for a PED, for improvement by a PED CNO 30. And then in the CNO CTP criteria for treatment failure, this is what we had included. We included a pain scale on a visual analog scale, total number of active lesions, number of radiographic lesions by a whole body MRI or bone scintigraphy, the size and degree of the lesions, a physician visual analog scale, and then inflammatory markers. And so kind of going back here, I'll stop and hear others' thoughts.
If I can kick off, I don't know what the process is. This is Ram from Bristol. I have an issue with both of the suggested ones because they seem to be sort of duplication of the ACR criteria for JIA. But when we tried to design a trial of pimidronate versus adalimumab, and which we published in PLOS One, the process, we found that just quantifying the number of MRI lesions is not really enough, because you can have lesions which can be present but be at different stages of activity. ESR is not universally elevated. Significant proportion of our patient populations have chronic pain, so we can't discriminate that as a variable of disease activity for clinical trials. So I think for CNO, going down the ACR 30 model of JIA or rheumatoid may not fit, and we may need to think outside the box.
So one thing to keep in mind at this stage of discussion is keep in mind what are outcome measures and response criteria on the one hand, and what are the domains that constitute a disease on the other. And it's often difficult, it's surprisingly difficult to separate those two. Because we, in our minds, we automatically go to, well, what's the outcome? What's the outcome? That we need to make sure that we keep them segregated. In terms of I personally think that that's very appropriate, because one of the things I was going to suggest just semantically is that you change the word radiographic to imaging in all of these things, because you're mixing together X-ray and MRI, for example, and then in one of those first ones, how do you even quantify what a 30% improvement in the imaging approach is, and how is that codified? Is it validated as a way of measuring that? I think it's fair to use imaging as a way of constituting the. You're defining the disease partly by showing lesions that are obvious on imaging. So you've got to incorporate that. But be careful that you don't then slip over into outcome.
Great. Others, thoughts?
This is Dan. I think it's pretty clear that we need to start this work, as our group has been trying, and Rem, a few of other colleagues have been approached by the industry as well. Clearly, there is increasing interest in this disease, but what are we going to be measuring? And thinking, one is to be truthful, just in the OMERACT spirit, but also reality. When it's submitted to the regulatory board, it's not going to be just MRI, and that has been repeatedly told to us. So I totally agree with Rem, but I think the work is going to be a long-term. Often we just jump into the instrument, but the first step, what Melissa has shown is a long list, and many of these are probably falling into the same core or same domain. So I think there will be more work for us to do to summarize from the literature, and also once we do the qualitative research, just to listen to what the parents and patients are going to say. So I personally think, yeah, it's the work we must.
Right. I was going to say that, like when a patient comes to the office and you write in your note sort of doing much better, we all know what that means. Like the patient comes in and they're feeling much better, and they've gone back to school and they're doing their usual things, et cetera, et cetera. And the question is sort of like how you actually break that down into its component parts, right? Because that's what we do clinically. We know what we mean when patients are doing better. So that's the question, is how you actually break that down.
Great. I don't mean to push people along, but we could probably vote on our first question for this one. I didn't think we would spend that much time on this, and would like to use the rest of the remaining time to talk about the other question. So We have a poll. I think this is so cool, this polling thing. So you guys can vote, and just in general, do we need a core domain set? And we'll be able to get this in real time, hopefully in like a minute or so.
I know, it's one of my favorite things. I just, it's fabulous.
Okay.
Can I just ask a controversial question that is
Yes.
also there to poke people a bit? Do we really need one core set, or do we need two for CNO and SAPHO?
So that is an excellent segue to our next question. So this really will be the I think a big part of the discussion today is, yes, so should we, essentially what Christian asked, should we be developing one core domain set or should we be developing two? And, you know, taking into consideration, you know, should we separate out pediatric and adult, and again, separate out CNO and SAPHO or include them all in one? So I will stop sharing and hear others' thoughts.
Melissa, I have a question for you. What
Yeah.
about things like people with CNO and IBD, or people with, you know, I mean, there's other permutations
Right.
of this, or people who have CNO and then turn out to have IBD or turn out to have psoriasis or any number of things.
Right. And so that'll also be narrowed down through the, you know, qualitative and literature search about improvement in extra osseous manifestations just with CNO. So really then how is that, you know, that much different if we have a, you know, include SAPHO with skin as well too and IBD stuff.
Before we poll, it's worth reflecting. The primary remit, if I understand, is, as you rightly pointed out, we don't have many randomized controlled trials. So there's a dearth of randomized controlled trials, either investigator-initiated or industry-led. And in order to have these, particularly industry-led, it might appear intuitive to have something which cuts across the age spectrum that enables us to do trials of novel molecules, be they be anti-TNFs or anti-IL-17s or 1223 molecules. So something for us to reflect on when we think, do we want separate domain sets or same?
Well, it just seems like, given the domain type of things that you've discussed, that you have to have separate sort of domains for the functional and types of things that kids do and adults do. Kids don't work, adults don't go to school. You know, the impact, disease impact is different. Maybe that can be incorporated into one set, but I think that's very different.
That's a great point. And I don't know if that's actually sort of gets into, do we have a one core domain set, but separate instruments or separate measurements when we eventually, in years from now, move on to developing our measurements?
There's also growth disturbance issues in pediatrics that you will not have in adults, and we don't want to miss kind of evaluation of those problems.
That's a good point.
Yeah, it's also I think also the frequency of certain organ involvements vary significantly between kids and adults. So an adult with SAPHO will have other personal challenges than a child with CNO and no skin involvement, or an adolescent with CNO and acne that's somewhat physiological in the age group. So I think it just complicates things. I'm not saying we shouldn't do it. I'm just raising a couple of concerns that may make it quite difficult or complicated to combine it.
I would like to agree. I think adults have to be separate, calculated from the childhood, because it will. I don't understand how to do it in one because due to different instruments and different different points. So
we slipped over from CNO versus SAPHO to pediatric versus adult without Melissa.
That's okay. I have a question for both of them. So go ahead.
I ask how he feels about this methodologically. I mean, if this is a course set, should we have one and then go on from there? I mean, what does Philip think? Since he's done this, you know.
So my first concern when I thought about the CNO SAPHO issue was, well, I started thinking, are we ultimately going to be shown that there's enough similarity genetically that it's legitimate to lump these together? But if that's not known, then are there enough clinical phenomenology features that link the two? And apparently, yes. That means, so I'm thinking that you're approaching this at the moment from that perspective, that there's a significant overlap with the exception of the skin in the latter. I'm curious if, Peter, I didn't mean to necessarily tug you into this, but when you've considered diseases that are really close cousins of each other, how have you experienced this historically in OMERACT in terms of isolating separate core sets versus lumping them?
Yes, that was my exact questions.
Yeah, I'm turning to a senior person.
Yeah, well, I think you have to work it through and find out what degree of commonality there is when you look at these separate groups. Look at them separately and see the degree of overlap and decide whether they should stick together or be different. We've been very surprised for lupus, vasculitis, all the other ones with multiple organ systems. You end up with an incredible amount of similarity around function and some of the other core symptoms. But then we've broken out the onion into this new onion that Peter Merkel inspired at the last one, in terms of trying to make sure that just in the appropriate patients, all patients have commonality with common things in terms of disability and pain, etc. But then there's the subset of patients with the other organ systems that are involved. You can also handle to actually focus your trials and be able to do your sample size. Thank you.
So you're using a very good example of vasculitis as a topic, and we all know that there are multiple forms of vasculitis, but that so there's a way of bringing them together at a core set level, but then when you have the Merkel onion, you can separate things out more.
Yep.
Okay. So that seems like a good advice.
Yeah, so that's a good point. You know, could we find some core domain set that's in this onion that fits in the mandatory domain that fits both CNO and SAPHO and adult and pediatrics? And then are there, you know, additional ones, say differences for CNO and differences for SAPHO or ages that can go in the important but optional section? Some of the things.
So I'm going to put in one request for keeping peds and adults together at the moment. And I'm thinking about one of the patient research partners that's involved with the group who has not developed a different disease in her adulthood. She has the same CNO issues as when she was young, and so hasn't morphed. And I'm thinking of another patient that I've recently seen, very recently seen, like just a few weeks ago, where she had ankle CNO, and that was a dominant issue when she was young. But now as an adult, she's developed classic non-radiographic axial spondyloarthritis. And really the ankle CNO is not an issue anymore. So in her case, I would agree that she's sort of morphed into something different now. But in the former case, I don't see them as different other than the fact that was pointed out earlier, things like, well, she's not going to school now, she's working, and sure, the instruments will be different. But I would argue that the disease process is the same. The pain, the function, all of these at a basic level are going to be the same.
I would completely agree with that.
This is Dan. I think some of the concerns I'm hearing is at this level, the core domain, probably we can generate one for all. But then when it comes to the instruments, there may be differences. And then we're going to talk about the SUFFLE, the difference between SUFFLE and CNO, and again, that is also, as Melissa has well put in the presentation, do they have the similar mechanisms or not? But clearly there is at least overlapping between the two. And thinking of just in general, pediatric transition to adult is always a challenge. Taking arthritis as an example, that, you know, when we transition our patients to adult rheumatologist colleague, we call it ERA, we call it a different, in a name, the oligo. What does oligo mean? And so some of the collaboration, I definitely appreciated the collaboration, the ongoing discussion, you know, between the peds and adult, you know, sides that we can work together. I think that's one thing I just wanted to bring it out and kind of stress the importance of that. And that's some of the patients that Phil has mentioned that started at childhood, but continue on with it. And maybe it's important to hear their input as well. And I know Alex is sitting in as a parent. You might be also, Vicky, I think you're also the patient partner. We would like to hear your voice here as well.
Yeah, this is Alex. I feel like with less clarity over whether CRMO and SAPHO really are the same entity or not, I'm trying to think of the practical implications, pro versus cons, of grouping them together in this process. And one of the things that I was thinking about is it would be really wonderful to hear from an industry stakeholder perspective, and I don't know if we have any in the special, right, with regards to, you know, these outcome measures are to be used for clinical trials. If industry is only interested in the more prevalent adult disease, very selfishly from the chromo pediatric, since that's the people and the population that I'm here representing, we could do all this work and then drug companies use these outcome measures to test in cohorts in patients, and so leaving pediatric individuals. Is that going to happen? Is that a worry? Is that a concern, a practical kind of downstream concern with regards to grouping everybody together? I'm just trying to think, again, from a fairly ignorant perspective, because I'm not involved in a drug development myself, of the potential negative impacts of grouping them together. That's just one thought that
I'm not imagining myself that that's going to be negatively impact because the companies will go where the money is. And at the moment, the money is in the pediatric. There are many more patients in the pediatric population, both to study and to ultimately use their medications in. So although it would be, I personally don't think that it will be a hindrance. I'm thinking of Novartis, I'm thinking of the various TNF companies, for example.
Yeah, I was just going based on the incidence numbers that Melissa presented in her presentation. It's like 40 times as many, the rates of incidence of SAPHO in adults versus
you mean,
CRMO.
I see what you're talking about, yeah.
So
CNO versus SAPHO.
If I may add to that, Alex, obviously I can't speak for industry, but in some of our preliminary discussions, and that's exactly the point as made out by Dr. Meese, if you have the same domains but different measures because the impact is different, it is more, one can intuitively, and based on some preliminary discussions, it's more interesting for industry to come to a disease which straddles the spectrum so that they can do something across the age spectrum for whatever reason. And also, if they do in adults, and we call the same disease by the same name or the same domains, then the pediatric study plan and the pediatric investigation plan, which companies are mandated to do if they do a trial in adults, will kick in. Whereas if we say these are two distinct conditions, then there are some issues with it. So obviously it's appealing for industry to have the same nomenclature, even though there may be different forces to play in terms of impact.
However, you know, we don't want to get into a situation where SAPHO is, you know, referred to as psoriatic arthritis and therefore not interesting to the pharmaceutical companies because they already have a product that's approved for that. And they don't want to do trials because they feel like it'll just be an extension of what they already have. I mean, I'm all for lumping because I don't think we can actually split. I don't think we can actually separate these diseases because they merge one into another, but I don't know that it's so inspiring to pharmaceutical companies to add an indication like SAPHO because I think that's already covered. And we should do what's right and worry about the pharmaceutical companies later.
That's good advice.
So we have adult rheumatologist here. From my discussion with the adult rheumatologist colleague before, even SAPHO, you don't see a lot of SAPHO in clinic. I think the number is it's not reflecting the reality. Can you comment on that? I don't think you have 40 SAPHO patients are in clinic, Phil, right?
I have 0 SAPHO patients in clinic.
I have 1 or 2, and it's really very rare, but such a sense that it's due to misdiagnostics, but not due to absence of these patients. So it's not question of corset domains, but question to absence of criteria that we use. So I feel that there are a lot of, because we had several patients with, they were diagnosed as axial spondyloarthritis or peripheral spondyloarthritis, but after we changed diagnostic from multiple osteomyelitis, non-bacterial, they improved on pamindronate, and I have a sense that the 10 years before they had wrong diagnosis and not due to absence of these patients. Maybe after improvement of diagnostics, we will see increase of these patients number in our practice.
We do need a new classification criteria for SAPHO too, or adult CNO, and unfortunately ACR-ULR didn't want us to do that. Just a little background information. They like the overall proposal a lot the year before we got awarded.
The criteria are not discriminative. That's why a lot of these patients could be diagnosed as spondyloarthritis and another spine disease patients, and not inflammatory disease patients, because nowhere is written that we use this criteria in exclusion of another diseases. So it's this problem is. But if we will talk about domains, maybe for children and for adults, we will have another course, different courses due to a difference in functional area of childhood and adolescence, because you see, we can't count, for example, work disabilities and so on in childhood and in adult in the same way, because and it will be very difficult to calculate everything in adulthood and childhood in one. But I think SAPHO and CNO has to be in one corset domain, because it's not so difficult to do an optional corsets for such domains like skin involvement and so on. It's not a problem, I think.
I agree.
That's a great. Vicky?
Sorry, go ahead.
Vicky?
Sorry,
Final
I agree
thoughts.
that it's I agree, it's not a problem to have an optional course set. I do feel that the instrument development can easily cope with the difference in loss of function for children and adults, because it is still a loss of function, a loss of interaction, a loss of self-identity and self-efficacy. Yes, it's affecting different activities, but I think that can be covered by the instrument and it doesn't need to affect the domain.
So it's a little after 5.
Yeah,
Time flies.
Segue into your vote, though. That was perfect.
Yes, perfect. So we have 2 more voting questions. We'll pull up this one first. I made this question before the discussion, so if it seems a little strange, then sorry. But first question is, how should we best incorporate CNO and SAPHO into a core domain set? So should we keep them separate? Should we keep them as one? Or the third was some kind of optional one where we just kind of focus mainly on CNO with some optional importance to SAPHO. So feel free to vote. And then do you have to wait for everyone to submit before you pull up the next question?
Yep.
Okay. And then I'll jump to Aruni and Eve for just quick summaries from today and the polling questions just to show everyone. All right. Okay, so we'll have to discuss this a little bit more, I think. But thank you, everyone. And then we'll pull up the last polling question. Is, do we include pediatric and adult populations into one core set? So should we include them, yes or no? While we're polling everyone, I don't know for Aruni and Eve if you've had some, I know you guys were taking notes and monitoring the chat. Oh, wonderful. Good job, everyone. I'll just kind of summarize some points from today.
Sure, we're still taking notes.
Okay, thank you.
But I think there were several common themes that were raised, starting with concentrating on the diseases, or sorry, the elements that constitute a disease rather than the instruments that we use to measure outcomes in the disease, and thinking about that as the frame for our core domain sets. From the first voting question, we had 100% agreement that we needed a core domain set for CNO and SAPHO. And then we quickly came into some challenges in terms of how to define these domain sets, whether they should be included together for CNO and SAPHO, and whether adult and pediatric patients should be incorporated into the same core domain set. It sounds like we have most agreement that pediatric and adult population should be in the same core domain set for whatever whatever we end up with. So 91% said yes, but we have a little bit more ambiguity about how we approach CNO and SAPHO, whether we are going to use the same mandatory core domains or have CNO as our base with SAPHO as the optional, including skin. Eva, if you want to summarize some of the points maybe that people gave in favor.
Yes, can you guys hear me?
Yep.
Yeah, so I think that I sort of see both sides, and I think, like Aruni said, there's definitely some ambiguity. And so there was, I think, some good points about maybe, keeping them the same from the core domain set, but when we get to mandatory items, thinking about how they're different between CNO and CRMO. As far as reasons to maybe think about keeping them separately is, that maybe there might be some different functional concerns between adults and pediatrics. For example, growth concerns that may not be applicable to adults, the different organ system involvement between, pediatric CNO and adult SAPHO. But then, as some others argued, when there's limitations in function, it's just at the end of the day, it's limitations in function, whether it's adult and children. So definitely seems like there's still some, I think, mostly ambiguity as far as that question goes, compared to the 3 questions that we've done. So definitely worth further discussion.
Great, thank you. So thank you, everyone. This has been a really great discussion, and hopefully we got some also, I saw in the chat some great ideas for how to reach out to stakeholders as well too, so much appreciated. And we will keep seeing each other. I had a quick thank you slide, sorry.
With your email.
Yes, so if anybody who is not part of our group wants to be part of our group, then please email me or Dan. You can probably find our emails easily, but I'll pull them up here. We meet monthly as a big group, as a big CNO work group, and then our OMERACT group meets bi-monthly. So yeah, please feel free to email us. Or if you have any other thoughts or suggestions, you can email me as well too. So thank you, everyone.
Thanks, Melissa and Dan and everyone for all the work. I mean,